going to go into what normal disfluencies are, then we'll talk about the characteristics of stuttering, what increases stuttering, different theories behind stuttering, assessment and treatment approaches, and then we'll also talk about something similar to stuttering called cluttering. So before we begin, I want you to understand that we've talked about language, we've talked about cognition, and then after your test we're going to talk about articulation. And fluency is one of those that we don't have a great grasp on what causes it, what it is, and it kind of encompasses a little bit of all of those areas. So it's a little bit maybe to do with language, it's a little bit to do with cognition, it's a little bit to do with articulation or motor speech. But we haven't quite narrowed down exactly what it is, and so that's why it's in between these sections in the course to try and encompass all of that. So the first thing you want to understand is what fluent speech is, right? What normal fluency is, and that is just effortless, easy, rapid, rhythmical, and even fluent speech. So it means that that speech comes out naturally. We're not having a lot of effort to talk. We have a rise and fall in our voice, and we have a little bit of a rhythm to it, right? We don't stop in the middle of what we're saying, right? It just keeps going. In contrast, for disfluency, you have many different forms of interruptions that prevent that easy, effortless, or smooth flow of speech. So it's anything that it starts to break down, where you have those interjections, you have repetitions of phrases, you can have revisions where you're correcting what you're saying, and you can have sound prolongations. And if you listen to yourself in normal conversation, or you even listen to me during this lecture, you're going to hear disfluent moments. It's going to have a little bit of a let me think of the word, right? That kind of pause or that interjection. You might hear me repeat different phrases, or I might revise where I said the wrong word, but I need to fix it, right? Or I'm trying to think of the right word or get the right word out, and so I might prolong those sounds. All of that's normal disfluency. Everyone is disfluent at some point in time, but we have to differentiate what normal disfluency is from stuttering. Alright, so stuttering is a disorder of fluency that's characterized by excessive amounts of disfluencies. So we measure that in terms of the frequency of those disfluencies, the types, and the durations. So let's look over at the disfluency types on the right side. We can see that for stuttering, they can have whole word repetitions where they say, she isn't coming with us. They could also have sound or syllable repetitions where they she isn't coming with us. There could also be audible sound prolongations where they're holding out that sound. Typically at the beginning, it may be other places in the sentence. They might say, she isn't coming with us. Or they can have blocks where we have inaudible sound prolongations. This is usually on stop sounds, which we'll talk about different types of sounds later. But that's where we're really kind of putting that effort into getting that sound out. So we might say, Dad isn't coming with us. Okay, they're really forcing that sound out. So when we're taking measurements for stuttering to classify, is it normal disfluency or is it stuttering, we're looking to see how often it's happening, what types they're using, and how long they last. In addition to that, when someone is characteristic of a stutterer, they might also avoid certain words or speaking situations. So they might realize that on sounds that start with the letter S, that they really have trouble saying those words, and so they might avoid words that start with the letter S. Or they might have trouble saying the word July, and so they'll avoid saying July at all costs. They might also avoid certain speaking situations. That's not only reading in front of a class or talking in front of a class. It could be talking to a certain person or talking to a person that you have a specific relationship with, so someone who is your superior versus someone who is your friend or a family member. And then they also could have associated motor behaviors. So in the further development of stuttering, they may start to grope for different sounds with their mouth, trying to find that placement and avoid the stuttering moment. They might also have breathing abnormalities where they breathe very quickly or they breathe at the wrong time. So a sentence might turn into, I went to the store the other day, where it really breaks things down because they don't have that coordination of their breathing and their speaking. They could also have facial grimaces where you see their eyebrow wrinkle, or they bite their lip, or they look confused. They could also have hand or foot movements where they're tapping their finger, or they're rolling their fingers together, or tapping their foot. It just depends on the person and their coping strategy for their stuttering. So when we talk about really measuring the difference between normal disfluencies and stuttering, we say, again, the frequency, the type, and the duration, but it ultimately depends on how you measure, and it also depends on the listener. So when we're doing a speech sample of someone we suspect to be a stutterer or a person who stutters, then we can measure it as when all disfluency reach or exceed 5% of total spoken words. So if we take 100-word sample and 5 of those words were disfluent, or 6 of those words were disfluent, then we can classify them as a person who stutters. We could also measure it as when part word repetitions and speech prolongations reach or exceed 3%. So if we take a 100-word sample, if 3 of those stuttering-like moments had part word repetitions or speech sound prolongations, then we can classify it as stuttering versus being just disfluent. And then we could also measure it as when duration of prolongation is 1 second or more. So it all goes back to the different types of stuttering in terms of how you're classifying it, or stuttering-like moments, meaning that they have those characteristics of sound repetition, sound prolongation, or blocks, or anything like that. Now, if you're looking at overall how you're measuring it, and maybe you have 6% in all disfluencies, but you only have 2% of part word repetitions, and you think, well, that's a little bit odd, a little bit off, then you can say, well, if the frequency is high enough to justify stuttering, then we don't have to measure how long they last. Or if there's a long duration, then we don't have to measure how often it happens. As far as the associated behaviors go, we have motor behaviors that I've talked about before. Either we call it pill rolling, where they rub their fingers together. They could be tapping their foot. They could be waving their hand. They could be tapping their fingers. Anything like that. They could also have negative emotions, where they have associated their speech with kind of internalizing other people's views of their speech. So I anticipate that this person is going to think less of me because I stutter, and so I'm going to, avoid speaking to other people. I'm going to feel bad about myself. I'm going to feel bad about speaking. They can also do circumlocution. So circumlocution is where they will indirectly speak of their chosen word in an unnecessarily lengthy manner. So instead of saying banana, they're going to say that yellow fruit that you buy in the fruit section of the grocery store, right? Because they know that they're going to have trouble with saying the word banana. So it's kind of beating around the bush of, I don't want to say the word I have trouble with, so let me find a way to describe it so I can get that point across. So why they develop these associated behaviors all goes back to that anticipation or expectancy. So if they've been a person who stutters for a long time, then they expect in certain situations or saying certain words that they're going to have that same trouble with stuttering in the future, and they're going to find ways to avoid it. And so when we classify these different behaviors, we have our primary behaviors, that's the excessive duration and frequency of the different disfluencies. And then we have our secondary behaviors, which are those counterproductive behaviors that they're using to try to avoid the primary behaviors. So I know that I'm going to have sound prolongation when I say the letter S, so I'm going to squint my eyes together to see if it'll come out better. But what happens is it becomes more automatic over time. So it's not something you consciously think about the first few times that stuttering occurs, but over time you kind of wrinkle the eyebrows together and it becomes this secondary behavior, right? It just kind of happens when you're talking. And the difficulty with that is that it often becomes more distracting than just typical stuttering. If someone is stumbling through words, or they are having a block, or it's taking them a little bit longer to get their message across, but you're really focusing on them tapping their foot, then it changes the way that you perceive that message. The secondary behaviors also increase with age. Primary behaviors can increase or decrease depending on certain situations, but the secondary behaviors, as they're trying to cope with the stuttering, tend to increase with age. So, the loci of stuttering is just when stuttering is more likely to occur. So it's different for different people. However, there are kind of certain instances that we expect it to happen more often. So it's usually words that are within the first few words of the sentence are more likely to be stuttered than the last words of the sentence. Also, the initial word of a phrase or a sentence, or the initial syllable. So it could be within the first few words of a sentence, it could be that very first word, it could be the very first syllable of the word. It could also be on consonants more than vowels, usually more so on longer words and words that you use less frequently. So we know that there are certain situations, certain words that affect stuttering and when it's going to happen, but it can also be more severe depending on the certain situation. So someone who has to present in front of people and they're not used to presenting in front of people, or they're uncomfortable doing that, or if there's a certain topic that either they don't feel comfortable talking about or they're not as familiar with, may have more trouble with the stuttering. They might also, if they didn't sleep very well the night before, they've been working really hard and they're fatigued, then they could also have more stuttering. So in general, speech is usually more fluent when it isn't bidirectional, which means that there isn't a conversational partner. You are talking out loud to yourself, you're talking to a pet, you're just kind of getting the message out, but no one's there to judge what you're saying. You're going to be more fluent. Also, when speech isn't used as a communication, so when singing or talking in unison or rote speech, things that you've memorized tend to not be stuttered. And then when speech production requires increased monitoring, so using pretend voices or using different accents can result in decreased stuttering. And then there's also something called delayed auditory feedback, which we'll talk about in class. And it's an earpiece that they put in the ear, and it gives a delayed feedback. So the microphone is worn on the shirt. It records or plays back what the person is saying into their ear with about a 1 to 6 second delay. And it kind of gives the brain a little distraction while they're talking, so they're not monitoring what they're saying, they're listening to what's happening in the ear. They may also be more fluent when they're reading, and depending on the person, when they're talking to a familiar person versus an unfamiliar person, being more fluent then. Some people are usually more fluent when they have familiar listeners that are aware that they stutter. And then they may be more fluent when there is pressure to be fluent. So if they are presenting in front of people, they're going to work really, really hard to be more fluent and stutter less. So I said before, we don't know exactly the cause of stuttering, but we do have a lot of theories behind it. So we've been through a lot of different theories over the years, and they're all kind of based in these three categories: either a neurophysiological or organic cause, an environmental or a diagnosogenic cause, or a conditioning and learning cause. So the idea for the neurophysiological or organic theories state that there is some type of underlying body structure or system that's defective in some way. So that can be either laryngeal dysfunction, where the larynx doesn't coordinate with the articulators, and so that produces disfluent speech. It could be that we have the right and the left hemisphere, and really the left hemisphere should be controlling speech, but maybe the right hemisphere is trying to interfere. It could also be that speech mechanisms move slower, or the nervous system is unstable, so it's not getting the signal from the brain down to the articulators efficiently. They could have a defective auditory feedback loop to regulate speech. So remember, when we're talking, we have that feedback to ourselves to tell us whether we said something correctly or not, and maybe their loop is ineffective. And then a very outdated one: if you were born left-handed and forced to use your right hand, then you were more likely to stutter. And so these ones that I've crossed out here are ones that they really say we don't have a lot of evidence to support it. We've talked about it in the past. We've looked at it to see if it has any foundation, and really we don't have that great of information to say that that is the cause of stuttering. From an environmental or diagnosogenic standpoint, their idea is that stuttering is in the ear of the listener. So initially they said, well, parents who have high standards for their children diagnose their children with stuttering, and then the stuttering starts. So the child didn't really stutter before, or maybe they stuttered once or twice because, right, everyone is disfluent, and they say, oh, you stutter. And now the child has a problem, and now they stutter, and it continues to be a problem throughout their lifetime. And again, we have evidence that says, no, that's not it. And then they have that the problem starts after the mistaken diagnosis. So it goes back to, again, everyone is disfluent. We say that the child is stuttering, and then the child continues to stutter afterwards. And then we have from the conditioning and learning that the idea of stuttering is a learned condition. So it is either a learned avoidance behavior where there is a negative association to disfluencies. So we have our typical disfluencies. The child gets frustrated that they're disfluent, and so they're more likely to stutter because of that. There's also the operant theory, where reinforcement of stuttering increases stuttering and punishment decreases stuttering. There's the two-factor theory that says that different disfluencies have different causes. So we'll go back to the different types of blocks, sound prolongations, word repetitions, or sound repetitions. And it says that for each of those, each one has a different cause. And then there's classical conditioning that says that a certain stimulus evokes a response. So when they're in a stressful situation, they're more likely to stutter. When they're talking to an unfamiliar listener, they're more likely to stutter. And so that's the cause of stuttering. And then there's one related to external conditions that says that the communicative environment, the linguistic context, and the cultural differences can really impact stuttering. So we are not born to stutter, but given our certain environment, we can develop stuttering. And so ultimately, we don't know the cause of stuttering. Okay, so there are lots of theories out there. They continue to study it and figure out what exactly is the underlying feature, and they really haven't narrowed it down to anything specific. But if we think about motor speech, so getting those articulators to move, to get your lips and your mouth and your teeth to coordinate and close at the same time to make the t sound, to get your larynx to do things at the right time, so that you have a voiced sound instead of a voiceless sound. If those are all uncoordinated, does that result in stuttering? Or does every child that receives negative feedback stutter? So if you tell a child, oh, they did something bad by playing with a certain toy or getting into the garbage can or putting a bracelet down the toilet, are they going to stutter afterwards? Or does every child that's stressed stutter? So a child who goes through divorce and their best friend's parents go through a divorce, are both of them likely to stutter? Not really, right? When you think about it, all of these factors can influence a child's outcome, but it's not really the cause of stuttering. It can happen because of these events. It doesn't necessarily happen as a result. And then think about for family history. Does everyone who has a family member who stutters stutter? If you have an uncle that stutters, do you stutter? No. Does the uncle's son stutter? Maybe. Does the daughter stutter? Maybe not. But ultimately what we know is that the heredity and environment play a part in etiology. So if people have a family history of stuttering, your uncle stutters, then it's more likely that his son is going to develop stuttering. It also is more likely to run in males, so it's less likely that his daughter is going to stutter. And we've thought about neurology and how their underlying language centers could have an influence on stuttering, but that doesn't mean that we all have that same neurophysiology, that we're all born with this innate way to not stutter. It just means that maybe we have this mechanism, and in the right environment, it results in stuttering. And so it's just something to keep in mind, and that's why when we go into things about treatments, that it really becomes difficult in finding the right treatment for the right person. So when we do an assessment, we're going to do very similar things as before, in terms of the language and cognition. We're still going to do an interview and a case history and asking specific questions. So those specific questions can include, when do you notice that you stutter more often? How do you feel about your stuttering? Does it upset you? Does it bother you? Do you notice if anyone else knows that you stutter? Does anyone make comments to you about it? Are there certain words that make it worse? Is there anything that makes it better? And then you also do a measurement of disfluencies in a variety of contexts. So again, we do our conversational speech, we do the oral reading, and then we also look at the home and other situations, so maybe in the classroom. And this all goes back to the likelihood of stuttering. So if we know that a person stutters more in conversational speech with an unfamiliar listener versus a familiar listener, then that's something we want to target in therapy, of working with unfamiliar listeners. And then we do an assessment of the associated motor behaviors and emotions. So do they have any of those little tics where they crinkle their eyebrow or tap their finger? Do they avoid certain words or certain situations? And do they speak quickly or do they speak slowly? And then we use standardized testing. There aren't very many standardized tests for fluency, but there are some available out there. And so we might give that to the person depending on if they're in the appropriate age range. As far as treatment goes, there's lots of different ways to treat stuttering. It's gone through a lot of different theories and through a lot of studies to try and figure out what's causing it, which in turn gives us, if we think that this causes it, maybe we can treat it this way. So as far as psychological methods go, it can include psychoanalysis, psychotherapy, or counseling, and that's really talking about the personal, emotional, and interpersonal problems related to stuttering. And you're really looking at the root of stuttering. So is it because of how we feel about stuttering, how we feel about the way that we talk, that's causing the stuttering? And from figuring that out and being more comfortable with stuttering, can we decrease how often it's happening? From a speech pathology standpoint, we do more of the stuttering modifications. So stuttering modifications can include fluent stuttering, fluency shaping, fluency reinforcement, or stuttering reduction. So for fluent stuttering, essentially what you're trying to do is reduce the secondary behaviors. So reduce the crinkled eyebrow, reduce the finger tapping, reduce the circumlocution or avoidance of certain topics. But ultimately, you're not trying to eliminate those stuttering like disfluencies. So you're not trying to get them to stop having the sound prolongation or the blocking. You're just trying to get them to reduce all of those distracting behaviors. On the flip side of that, for fluency shaping, you're really trying to reduce stuttering by promoting the fluent speech, and you're not focused on the stuttering secondary behaviors. And so by doing that, you're really trying to promote easy onsets and promote taking your time, taking a second to respond, really just breaking down all of the different ways to eliminate those stuttering characteristics. And then for fluency reinforcement, you're praising fluent utterances, but ignoring disfluent productions. So that's really saying, if the child's talking to their parent and they had a disfluency, they go, oh, try that again, right? And they have to repeat what they're saying. But if they say it without disfluencies, so they have a very nice fluent speech, then the parent goes, oh, that's great job. I understood exactly what you meant. You said that really well. And then there's stuttering reduction. So that's just really reducing the rate of speech. So slowing down while you're talking to try and reduce how many disfluencies you have. Now, there are some treatment problems because ultimately we can't cure stuttering. It's never going to just magically go away. A lot of what we do is like that, right? We can't cure aphasia. We can't cure right hemisphere disorder, but we can reduce how much it's impacting the person. How effective our treatment is really relies on how much the patient, the family, or the parents are involved. And then how much patience they have with working on their strategies to use not only in the clinic but at home, and then acceptance of the fact that they are going to stutter. It's just a part of life that they're going to be disfluent. And just like someone who doesn't stutter is disfluent, it's okay. We can move past this moment and not get trapped in it, and then we'll continue talking and continue speaking, because ultimately the message is what's most important, not the fluency of the speech. And so when it comes down to working in clinic with easy onsets, so really gently moving the mouth and the lips or the tongue so that you have just very easy speech, you're talking a little slower, you're taking breaks in between each of your sentences, you're using simpler words, is great when you're doing it for a short amount of time. But if you think about a person who stutters, they're going to constantly think about what they have to do to get that fluent speech. And so it's difficult to stay fluent for a conversation or for a presentation or throughout the day. And so what ultimately we're trying to do is generalization. And this is the same for everything that we treat. We have to carry over our clinical practice. So practicing words in the clinical session, practicing talking about ourselves, practice with whatever area we're working on, and transferring that over into everyday situations. So it's great that you made a 100 on my test in the class, but it's not so great if you walk out of the class and can't use any of that information. That's what generalization is. Can you use that information in everyday life? And as far as stuttering goes, it's one of the more difficult things about that treatment is getting them to carry over all of the things that we give them into that everyday situation. So what's the best approach? It really depends on the client. Often it's a combination of different strategies. So it may work very well for a while for them to use very easy onsets, or to speak slower, or to think before responding, or take a break before responding. Or they may even benefit from delayed auditory feedback for a time. But it really is a trial and error in finding the right thing for that person at that time. What we're finding now with stuttering is also just acceptance of stuttering, that it's going to happen and it's okay that it's going to happen, and the more that we accept that and move on with it, the better the outcome, so that the stuttering severity doesn't increase over time, where they start as a child very young, stuttering occasionally, but the more frustrated they get with it, the worse that it gets. But if we promote acceptance of stuttering from a young age, maybe we can keep it at a mild stuttering or severity level. And so if we are working with a child at a young age, we really want to get the family involved, because they're the ones giving the child feedback to say, you're doing a great job, I got that message that you were trying to get across, or you weren't. And so a lot of times when you're doing an evaluation on a child who stutters, one of the first things that the parents are going to say is, I tell him to slow down, and I have him repeat himself, or every time he's fluent or he says the sentence, easily and I can understand it, then I say, that was a great job, you said that great. But really what that puts the focus on is the fluency and not the message. And so we want to promote good communication between a family member and a child, and so we want to encourage them to maintain eye contact, to not finish sentences or to speak for the child, and then to not interrupt them. So the more that we encourage them to see that I can communicate in this situation, it's a safe environment, my message is the most important thing, we can decrease how much the stuttering can increase over time. As far as communicating with the kid, they can also reduce the length and rate of responses, or reduce the complexity of responses. So this is where the foundation of stuttering, or the theory behind stuttering, goes back a little bit into language, where we think maybe it is just kind of overwhelming the language areas, and so they're trying to put the pieces together from the message as well as give us a sentence output. And so if we reduce how much we're saying and how fast we're saying it, then maybe we can reduce the amount of stuttering. And so it's just giving that child time to get the message that's coming in from the parent, so that they can have a more fluent output. We can also encourage waiting a second before responding on the child's end. So if the parent says, how was school today, instead of saying, oh, it was great, or, stuttering through that moment, they can take a second and respond. And we can also encourage positive feedback during fluent moments, but that doesn't mean that we discourage disfluent moments. It just means that we have to allow the child to work through that. All right, so we finished up on stuttering. There's also a kind of a subtype that we're going to just briefly talk about called cluttering. It's a newer thing to our field, but it's something that's kind of interesting because it can be misdiagnosed as something else. And so cluttering can coexist with stuttering, and it's essentially just impaired fluency with rapid but disordered articulation. They may also have disorganized thoughts and language production, and jerky or tumbling speech. So it's just a child that's really kind of stumbling through their words, having very choppy sentences. And their main characteristics that differentiate them from stuttering are telescoped words or syllables. So this is just essentially compressing or deleting a word or a syllable. So instead of parliamentarian, they might say Pamarin. They could also have spoonerisms or unintentional interchanging of sounds. So instead of saying dog, they might say ogd, right? And it's a little bit backwards. And it's just, they don't mean to, they're not playing with words, it just kind of comes out that way. So that's it for this lecture. So essentially you just need to know the difference between stuttering and disfluencies, and the different treatment approaches, and cluttering.